It's my pleasure. I'm Kenton Zaire. I'm the Executive Director for the Cardiovascular Service Line for the DMC. And I share the panel tonight with our speaker, Dr. M. Chadi Al-Reyes, who is our Cath Lab Director at the DMC in the Adult Central Campus. Chadi has a special interest in the cardiovascular effects of COVID. He's given this lecture before, which is a very insightful lecture. And now we have some updates as we're now through 4 phases of the disease so far. And I guess I could say I'm anecdotally happy to report that we're not seeing so many patients anymore. And the ones that we are seeing aren't nearly as affected as the ones that we first saw in the initial phase of the disease outbreak. So I think Chadi's going to play the introduction for us, and then we'll get started.
Thank you, Dr. Zaire, for introduction. We'll start with the video and then go to the slides.
It weighs less than 1% of our body mass and is an engine that never stops, pumping almost 2,000 gallons of blood along 60,000 miles of blood vessels every day. Our hearts perform like nothing under the sun. So when your heart needs care, you want a team of experts, board-certified heart and vascular surgeons with over 40 years of combined surgical experience, trained at some of the nation's top institutions, like Johns Hopkins University and Mayo Clinic. True specialists in the fields of non-invasive cardiology, interventional cardiology, cardiac electrophysiology, cardiothoracic surgery, and vascular surgery. For over 3 decades, our specialists have been available in Commerce and Detroit because we believe heart care isn't something you wait for. DMC Medical Group, trusted by the hearts of Metro Detroit.
We are really excited to be almost over with this pandemic. And I remember the first webinar we did together, it was really about how to handle the pandemic. And now we are talking about what is the impact of COVID during and after the pandemic. So just to give a brief about the COVID-19 and how does it impact acute myocardial cells. Myocardium cells these are the cells that are special compared to skeletal cells, but usually has also a special effect during COVID. So the myocardial injury happened during COVID pandemic at 20 to 30% of COVID patients. These are the patients who presented with symptoms of COVID as well as have respiratory symptoms, and they have what's called elevated troponin and injury. But associated with a high risk mortality, meaning the more you if patient coming with COVID and have myocardial injury, the chances of having more heart failure, heart attacks, need for any cardiac intervention or surgical intervention or ECMO is higher. Something in the biostatistic called the overall case fatality rate during COVID is low. But again, this is more special in comorbid patient. For example, patients who are at risk, who has underlying cancer, has hypertension, chronic kidney, lung disease like COPD and diabetes. But those who have underlying heart problems will jeopardize the most from the COVID infection itself. So what is the mechanism of COVID-19 infection on the myocardial infarction, on the myocardium? The patient present either with acute coronary syndrome, meaning elevated troponin, or because there is so much stress on the myocardium, causing the heart muscle to work harder, causing what's called demand ischemia or type 2 myocardial infarction, or because there is not a true luminal disease in the epicardial arteries. Is more kind of inflammation in the myocardial cells and microvascular ischemic injury. So inflammation is the main culprit here. Inflammation is caused by this big surge of response of the body cells to the infection itself, causing the heart muscle to get jeopardized by this infection. And when you have a biopsy as shown on the slide here, it always shows in these patients who had COVID itself and have myocardial injury, they have a low-grade myocardial inflammation, but it's localized within the macrophages, but not cardiomyocytes. What that means is there is no true heart function or heart muscle injury. It's the inflammation around the heart muscle what's causing the heart muscle to get weak or get compromised. One of the things we noticed, and we published about this before, that there is during the pandemic, and I'm talking about 2022. I just want to note here, for anybody who has a question, we'll be happy to answer these questions in the chat box or in the Q&A box. But I just would like to highlight a few things back in 2020. I think there was less patient coming to the cath lab. There is less patient going to the OR for bypass surgery, but there is an increased patient those who need ECMO or support for VA or VA ECMO for respiratory distress or due to acute respiratory failure. And we hypothesized, when I put that on Twitter back then, if you see the tweet there back in April 2020, that I told the audience would why we are having a low number of patients coming to the cath lab. What are the reasons why these patients don't show up? So most of them agreed, first of all, that there is a decrease in the ACS presentation, all these patients who comes to the cath lab first place, in more than 50% reduction in the number of patients coming to the cath lab. So when we took this survey, also submitted to a journal back in 2020, and we say, look, there's a drop in the presentation. This is really significant. And we know this is not because heart attack did not go away. They are still there. But at the same time, we don't know why. And these are the hypotheses, either because patients are afraid of coming to the hospital because they don't want to get infected, because they know this is during the pandemic, all the resources are utilized towards COVID patients, but also most of the patients in the hospital are COVID infection. Social distancing and also economic lockdown make the patient are less sedentary and less active to trigger any symptoms. And also there is the losing health benefit because people lost their job, so they don't have access to healthcare. They don't see their primary care that often. They don't get examined in real time, mostly we're telemedicine and so forth, and other reasons why the patient are not showing up to the cath lab. Again, these are all hypotheses, but are majority of them down the line, and later on we figured that this is majority of the case why the patient are not coming in. And we did survey all the cath labs in Michigan and also other states, maybe one in New York and also in Missouri. And there was a significant drop between 2019 and 2020 by 46% reduction. And we published these findings as well. These patient comes late, and as Dr. Zair attests to that, I mean, these patient comes late to the hospital. They have a lot of myocardium has been lost. Patient comes with akinetic walls on echocardiogram. People are we cannot salvage this myocardium because they have been infarcting for a while. Or patient, maybe they didn't make it to the hospital itself and they died at home or en route coming to the hospital. And we have seen a lot of these cases, unfortunately, over the course of 2020 and beginning of 2021. So one of the things that we also published back then is what are the COVID-19 impact on cardiovascular system? What are the histo as well pathophysiological controversies in this cohort of patients? So number one, there's no difference when you evaluate somebody with COVID-19 infection coming with myocardial injury. There's no different than any other patient. You should treat them the same. But we noticed that there is a tendency for higher arrhythmias like VT, atrial fibrillation, ventricular tachycardia, but also there are more patients coming with shock requiring ECMO and surgical evaluation, like Dr. Zair and his team do a phenomenal job at DMC of really taking patients within and also from outside hospital to treat them with VV ECMO and give them the best chance, giving the resources, restraining resources in other systems, and also because of the limited number of circuit available for these patients. And then there was a lot of controversy about the medication. These patients who comes with a heart disease as well as COVID, what are the medication? Are they going to behave the same thing? Should we give them the beta blocker? Should we give them the ACE inhibitor? And what is the role of other new agents that has been proposed to help these patients coming with cardiovascular disease? Again, there was a lot of controversy about the ACE inhibitor and also the ACE inhibitors and ARBs increasing the chance of infection because they opened the receptors for this COVID vaccine to get in. And that was a myth and never been approved in multiple studies after that published in the New England Journal of Medicine. So the proposed management back then is for STEMI and NSTEMI, we have to utilize resources, we have to multiple governing bodies in cardiology and cardiovascular societies talking about how we manage these patients and are we going to treat them differently. And if you notice that all this publication came within the pandemic year, between April all the way to September of 2020, people were hungry to know how we manage these patients, how other people are managing these patients. And there was, I mean, anything you submit to these journals during that time related to COVID, you get published. Why? Because there is a big hunger and big demand for to understand this disease state and how to manage these patients. So back then, we all these patients kind of come in a single room. We treat them. We have one called kind of COVID room, kind of treat just the COVID patients. Only the patient who's coming with requiring high level of suspicion to the cath lab, or high level of suspicion of heart injury comes to the cath lab, and so forth. I don't want to spend too much of time of what we have done before, but this is kind of one of the things that kind of standard of care was the same in terms of management of anticoagulation, antiplatelet, statin, and beta blocker and ACE inhibitor never changed at all during the course of the therapy. But for sure, we notice an increase in mortality, and I'll come to that in a minute, and how we triage these patients when they come to the cath lab. I'm going to leave an ample time at the end for questions, so please don't forget to post your question in the Q&A and the chat box as well. So I'm going to just, for the sake of illustration, is going to present a case for a 48-year-old female presented with indigestion, and it turned to be that she is COVID patient, presented in 2021, coming with chest pain, shortness of breath. She has some risk factor for heart disease, but she is a young lady. Blood pressure was elevated, the troponin was elevated as well, and ER, rightfully so, did an evaluation with a 12-lead EKG, and as you see there, what's called the tombstone or ST elevation in the inferior lead, and therefore that triggers the patient to come urgently or emergently to the cath lab. This is the first angiogram done. Again, you see there is an acute filling defect and abrupt stop of flow in the RCA, and you can literally see there is a filling defect in the artery that's suggesting a heavy clot burden. So in these cases, most of the time we give anticoagulation, which is in this case aspirin, antiplatelet aspirin, and ticagrelor, and also anticoagulation with heparin. And also sometimes we step it up to give what's called 2B3 inhibitor, which is a receptor on the platelet to kind of dissolve these clots and give it better chance for flow afterwards. So because of the heavy clot burden, we did thrombectomy, and this is a thrombus aspiration catheter just to evaluate and suction out these clots. And sure enough, we were able to get a very organized occlusive clot from the proximal right coronary artery. And in this case, you can argue the artery looks good. There is no need to stent, but anyway, the patient ended up with a stent because the clot just was completely occlusive after the acute plaque rupture. This is the stenting, and eventually the angiogram on the right showing the final angiogram suggesting complete flow restoration of this patient. So patient had a 45% basal inferior wall, was slightly hypokinetic. And again, this patient has been symptomatic for a few days prior to coming here. But just to illustrate the heavy thrombus, we see this in normal cases without COVID? Yes, we do. But this was kind of also a semi-late presenter coming to the cath lab with these clots as well. During the course or during the pandemic itself, we were lucky to be at DMC. We were lucky to be part of a big registry that really helped a lot, answering a lot of questions related to COVID-19 and how to manage these patients. So that's what was the birth of what's called the NACME registry, or this is the North American evaluation of myocardial infarction registry in patients with COVID infection. And the first time we published that was in April 2021. We published a report and the impact of ST elevation myocardial infarction in patients with COVID, and what are the predictors for adverse outcome, and what is the impact of the disease itself in this cohort of patients, and compare them with a reference cohort of patients matched but never had any COVID during that period of time. So the STEMI during there's a typo here, STEMI in 2020 COVID pandemic, 36% of the patient went for medical therapy. Primary intervention was in 71, CABG was 2%, thrombolysis therapy, meaning giving TPA, 3%, and facilitated, meaning you give thrombolytic and then transfer the patient for a hospital that is cath lab equipped to do an intervention, was in 4%. In terms of the impact of the COVID-19 on these patients, now in blue, these are the patients with a COVID positive infection who have ST elevation myocardial infarction. The red bar is the patient who are admitted with questionable infection, meaning a patient under investigation or PUI. And the gray or dark gray or black bar is the age and sex match control for patients who have similar presentation, similar demographics, similar comorbidities, but they did not have ST elevation myocardial infarction. They did not have, COVID infection. So if you see their difference, and this is during the year of 2020, a whole year, and the beginning of 2021 of COVID patient, you see the difference in outcome. Very statistically significant outcome in terms of the size of the infection, the stroke, but most importantly, if you see here, is the mortality. These patients definitely did not do well. But again, you'll argue, are they dying from the ST elevation itself or from the COVID itself? This is, again, was hard to differentiate, but definitely COVID was a main contributor, especially with the patient who have active respiratory symptoms. Length of stay, and this is, again, for hospital administration and others, a big burden and strain on the resources of the hospital, because these patients stay longer, they get sicker, and then it was one of the challenges, for example, we related to is to reach out the family who are making decision for these patients to see how far and how long we need to support these patients. What are these? The presentation, again, this is a central illustration of the paper back then. Again, COVID positive patient were 230. And then when we compare, majority of them are non-white cohort of patients, and majority of them, of the non-white, were African-American cohort of patients. They have more pronounced symptoms in terms of respiration, and they have higher BMI or higher weight, more obese patients, as well as they have less likely to receive primary intervention because they were so sick, or because they want to do what's called thrombolytic therapy. So we summarize based on this findings, the COVID patient with STEMI represent a high-risk group of patients with a unique demographics and clinical characteristic, but timely primary PCI is feasible and remains the predominantly reperfusion strategy supporting current recommendations. So meaning that we have to continue to treat these patients the same, and would not to exclude these patients when they come with ST elevation myocardial infarction, regardless of their infection state. Based on that study, we generated what's called the NACME score to see how we can evaluate these patients, the severity of illness, how we can classify these patients, and when to bring them to the cath lab or to refer them to surgery for bypass surgery. Again, we generated the score again, and then our numbers, I mean, there was a big limitation, is our number of cohort of patient is small. So this is usually require thousands of patients, because we are looking at very narrow cohort of patients with COVID and STEMI. The score was generated based on this cohort of patient. But again, if you have a score of more than 25, you are likely of hospital mortality is high. Anything from 9 and above should be brought to the cath lab or referred to surgery for revascularization. Otherwise, this patient will never do well. Also, we use our own data, DMC data, I would like to put give a credit to our infectious disease and our IRB patients, the team, who was able to kind of expedite the review for this IRB when it's related to COVID infection. Infection control team, they were very involved and very proactive in approving these protocols for us, which is, I was really delighted to see that. And we were able to submit this proposal to look into our DMC cohort of patients and who have heart failure and got COVID. And if we have medical therapy would change the course of these patients. And as you can see here from this abstract, there was no difference. So heart failure itself was an independent predictor of adverse outcome in patient presented with COVID. So if you have a heart failure, confirming what is known before, and also more importantly, 75% of the patients in our study were African American, which is majority of the population we treat in Detroit and Southeast Michigan were African Americans. So if you are African American, obese, and have heart failure, your odds of having and come with COVID, you have a definitely higher mortality, definitely higher length of stay, and definitely higher chances of going to long-term rehab after being discharged if you make it outside the hospital. Now we moved, we took it one more step further with the NACME registry. And we said, okay, how we can compare these patients who presented in 2020 during the pandemic to those came with STEMI and COVID in 2021. Is there any difference? What have we done in the medical field to change the outcome of STEMI patient with COVID infection? So what we did, we compared apple to apple. These are the same patient, but group of patient came in 2020 and other patient came in 2021. And as you see here, blue is 2021, blue is 2020, and the red is 2021 cohort. And you can see just looking at the graph, composite outcome in terms of anything, death, stroke, myocardial infarction, acute kidney injury, requirement for ventilation is lower in 2021, less mortality, less strokes. Reinfarction again is comparable. Length of stay is shorter, and also total length of stay in the ICU is shorter. So you will question, so what did we do here? What is the thing, the intervention that we have done? It's nothing really, to be honest with you. It's just the fact that we know more how to treat these patients. It was almost a year of the pandemic, how to deal with it. So the fear of treating these patients, the vaccination itself coming to the market and also available to the public made the outcome of this patient better. And I would like to highlight more about this. When we certify these patients, vaccinated compared to unvaccinated, again, I would like to give more a background. These are the patients who came with acute myocardial infarction in 2021 who are vaccinated compared to those who are not. As you see, there's no difference in terms of their presentation. The p-value is really across above 0.05. So all these are not significant. But when you look at the clinical outcome in terms of mortality, the patient who are vaccinated had better outcome. Stroke was the same. There was reinfarction almost the same, but the composite outcome also was favoring the patient with vaccine. Granted, the number, I would like you to pay attention to the ends here. The vaccination is only 22 patients compared to 171. A small number of patients, but again, if you involve more patients, maybe we're going to see a bigger difference between these two cohorts. So definitely vaccination helped. Definitely vaccination made these patients less sick when they come to the hospital, and they made them recover faster and leave faster. This is kind of a central illustration of the paper when we published it in 2020, just like earlier this month in June 2022. Again, I was really privileged to be part of this team at representing DMC on this big registry. So in 2020, you see the number of non-Caucasian, majority was non-Caucasian in 61% and continue to be, but less in 2021, 42 compared to 61. Symptoms of respiratory distress, less symptoms, 56 compared to 42. Infiltrate on X-ray, less. Cardiogenic shock, less. And then vaccination again, patients. And then eventually, the all-cause mortality in the hospital was also less. Why? Because the strain is different. People start to get adjusted to it. People start to come back to the hospital to treat their chest pain and heart failure. People start to come back to see their doctors in the clinic. The virtual or telemedicine kind of got minimized. And really our heart examination, heart clinic is very hard to just do it over tele. Definitely it's helpful for people who cannot come, but we are really very physical exam driven specialty. We have to see evaluate the swelling, the edema, to see how the patient looking. You cannot really judge somebody by looking him by like 6 by 6 inches window to see if they're really having distress or having heart symptoms. And even most of the time when we tell them to go to ER, they refuse. So again, this is why the presentation is better in 2021. The outcome is better in 2021. Again, please, if you have any question, use the chat box or the Q&A box. So what we concluded from this re-evaluation of the registry, so there was significant change have occurred in the clinical characteristic, management strategy, and outcome of STEMI patient with COVID-19 infection during the course of the pandemic. But mortality was 25% lower for patients treated in year 2021 compared to 2020. And again, there was remained to be a high rate of unvaccinated patients in that cohort. So I would like to move from the heart, purely heart and acute myocardial infarction into another topic, which has been kind of a lot of public kind of raising awareness. The radio, the media kind of bring a lot of attention. Oh, if you have COVID, you have blood clots, legs or DVT or PE. And sure enough, I would like to start with this case. This case patient came to the hospital because she was had hysterectomy recently, but also she was diagnosed with COVID. She came and CT showed a PE. And again, this is the CAT scan showing bilateral segmental pulmonary embolism, and the ratio of right ventricle to the left ventricle are almost 1.2 to 1 ratio, suggesting there's an RV strain. So he was taken to the cath lab, and sure enough, we took a big blood clot. This is, and I would like you to show the centimeter, 17 centimeter clot coming from that lung from both sides, but it was very organized. Is one piece, suggesting a heavy clot burden, more inflammation, and I think the COVID contributed to that. Having the fact that she just has surgery as well increase her risk for blood clots. So what do we do? We looked into this as well, and we said, okay, what if somebody with COVID, are they at higher risk for PE? Sure enough, there was a 20% increase of COVID patient coming with blood clots in the lung compared to patient coming during the pandemic but did not have COVID, with chest pain or shortness of breath. But what is the outcome of these patients? It looks like if you have a COVID and you have a PE, and you have advanced lung disease, you're gonna do as worse as the other cohort of patient. And this is what we showed in this meta-analysis that we published in 2021. Another example of blood clot. I mean, again, I'm sharing my own personal examples because this is what we have treated here at DMC. 68 came with shortness of breath. She has COVID symptoms, but she was hypoxic, oxygen saturation was low, and sure enough, found what it's called settle PE, which is meaning a settle means a big clot involving the main branches of the lung and also extending to the other branches. And sure enough, we were able to extract this clot in one piece, very organized, very hard to remove, which came out with the sheath in order to take it out, but we were successfully able to extract it. And nicely, we saw a drop in the pulmonic pressure from being mean pulmonic pressure of 31, went down instantly after removing this clot to 21. There's other options to removing these clots. For example, if I'm doing surgical thrombectomy, this is what Dr. Zer and his team have been done before, but this one was done in the cath lab with what's called catheter-based therapy for patient pulmonary embolism that we do here at TMC. I would like to touch on this kind of controversial but yet important topic is what are the impact of COVID-19 vaccination on cardiovascular outcome. I was invited not too long ago, maybe six months ago, to on a radio show to talk about a recent paper that was published in JAMA surveying European as well as North American, saying if you are getting the COVID vaccine, you are at higher risk for heart disease, meaning the vaccine itself affecting the heart in the wrong way, meaning patient having chest pain, coming with pericarditis, or having myocarditis, inflammation of the heart muscle. And sure enough, there was a small percentage, which was 2% of the vaccinated people, especially those with who were younger, male, who are very active, have higher tendency to have what's called adverse cardiac events when they receive the vaccine. So in order to address this thing, we wrote this kind of extensive international, you can see the names all international from everywhere, is talking about the impact of COVID vaccine on cardiovascular outcome. And sure enough, there was definitely a 2% to 3% impact of the COVID on the myocardial cells, on the perimyocarditis, inflammation of the sac around the heart and also part of the heart muscle. There was some arterial thrombosis causing leg ischemia, stroke, and Takotsubo or stress cardiomyopathy in patients receiving the vaccine. All this together was in the range of 2 to 3%. So, and then when we looked into how about if we compare this to the patient who received the vaccine and what are the outcome of these patients, it was lower. Meaning, although there was a low rate of adverse cardiovascular event in patients receiving the vaccine, mainly pericarditis and myocarditis, which is a benign or a low, I would say, one of the low risk side effects or myocardial injury in these patients receiving the vaccine, especially in young adult. But still, the benefit and effectiveness of the COVID-19 vaccine trumps their risk of the aforementioned sequelae, which is the risk of pericarditis and myocarditis. So I would like to leave some question and also discussion with Dr. Zair. But so what are the effects of COVID-19 pandemic on cardiovascular disease? I think we can summarize it purely in these bullets. Definitely earlier on, and when we were in the pandemic, it caused delay of the ideal care during the pandemics at most centers, not just us, everywhere, because of the fear of coming to the hospital, and patients don't want to seek medical attention when they have these symptoms. 2, there was worse cardiovascular outcomes, especially in COVID patients who are symptomatic, meaning the people who have lung infiltrate, the people who are hypoxic requiring oxygen. But also, recent COVID strains have less adverse cardiovascular effect. And I don't want to mention it here. We're in the process of analyzing our own data with a more recent COVID pandemic, which is end of 2021 and beginning of 2022. And we noticed that these patients really comes and go in the hospital without any difference between those who are not COVID. As a matter of fact, when we do a pre-surgical or a procedure COVID test before they come to the hospital and surprisingly become COVID positive, these patients, when they go for their procedure, have no different outcome to those who did not. And vaccinated patients had better outcome and less mortality if they come with COVID symptoms and adverse cardiac event. And vaccine associated with low rate of cardiovascular adverse event, but benefit outweigh the risk of stopping this vaccine. With that, Dr. Zair, I would like to stop and open it for discussion and also to have your input and insight on how this COVID affect the surgical outcome as well.
Well, thank you very much, Chadi, for a nice overview. And I think kind of putting it in perspective of where we were and now kind of where we are. And I don't promote myself at all as a COVID expert, but both yourself and myself, we did see the whole pandemic through, and we had the benefit of seeing the patients early on and now seeing the patients now. And, we try to be outcomes driven and not anecdotally driven, but anecdotes surely play a role in how we assess the way this pandemic has progressed. It's very clear that the patients that came early on back in 2020 were very, very sick. In fact, I can attest to the fact that we had extreme difficulty getting any of the end-stage patients through on ECMO. Most of them died early on. And it was also very clear, as you noted many times in your presentation, that there were definitely bleeding problems with the clotting cascade. In fact, we lost 3 COVID patients on ECMO from intracerebral hemorrhage early on, which doesn't happen at all in young patients that are on, say, VV ECMO for other ARDS related reasons. So we clearly had, and those problems seem to have been are now more attenuated in the later virus, the later virus surges. Wouldn't you agree?
Yeah, absolutely. It's the strain, I don't know, again, I'm not a virologist, but definitely the most recent strain when the people come is less symptoms, infiltrates less, and definitely the chances of developing thromboembolic or even myocardial infarction is less when they get infected. Whether we are weakening that virus by getting more people vaccinated or because of the precautions we did during quarantine, I'm not sure how to explain that, but definitely the rate is going down.
Well, I do think that there's no question that the Omicron variant was less virulent than the earlier variants. No question about it, because if you look at the area under the curve of the last surge, which was relatively recent, we did not see a huge uptick in patients filling our ICUs or patients being referred for advanced therapy like ECMO.
Right.
The other thing is that our patients on ECMO that were COVID positive, that were severely affected, we actually were able to get them through to discharge. In fact, we discharged our last COVID ECMO patient about a month ago, and our last 4 consecutively made it through and survived to discharge and with what we think is going to be a good prognosis. So I think that the good news about this is there's no question that we're dealing with a more attenuated virus for whatever reason.
Dr. Zair, one of the questions comes, I mean, again, it's not mentioned here, but would somebody coming for elective surgery, like coming to see you and you book them for a valve or CABG surgery and they do a COVID test and they come positive, one of the questions came, say, would that patient have a worse outcome? No symptoms, no shortness of breath, no oxygen, X-ray is clear. One of the questions came, would you delay his surgery or her surgery to have it done? Or from your experience, these patients have done as good as other patients who are COVID negative?
Well, we have had, as you well know, we have had several patients in various categories. We've had patients that were COVID negative going into surgery and have become COVID positive after surgery. And we've actually had mortalities in that category. Patients that end up getting the huge stress of surgery, then get COVID, and then that's a real problem. We've had patients that we do emergency surgery on, and while we're in the operation, we find out that they were COVID positive from the outside COVID testing before they were transferred to us for emergency surgery. Patient, no problem. Yeah. No problem. Would have never known they had COVID had they not been tested at the outside hospital. We've also had patients that, as you say, they're relatively urgent indications for surgery, and then they come up COVID positive, but they're asymptomatic. And now more recently, we have just been weighing the risk benefit and saying, what's the risk of waiting on this urgent case versus, waiting them out for 10 days or so until we're sure that they don't have symptoms from their COVID, or just going ahead. And in the asymptomatic ones, we have now proceeded, and those patients have done just fine. Every one of them. So I think that, I think we just need to make wise decisions. If they're going to undergo anesthesia and they have a new cough and they have new chest infiltrates, surely we should wait if we can for any procedure.
Absolutely. This is, I mean, the practice. But again, it is very enlightening to see because now, because of the constraints we have, like every other health system as well, that we have limited slots to do procedures and surgeries, you don't want to delay a symptomatic patient from a true heart problem for just an incidental positive COVID test. Because as you mentioned, Dr. Zair, rightfully so, and I attest to that as I follow these patients with you, they do as good as somebody who has no COVID. And as long as you mentioned, they have no symptoms, just say clear, as well as no oxygen requirement.
Well, I mean, you alluded to it earlier. There was no question that the COVID limited the healthcare response for a variety of reasons early on. Yeah. It was both on the patient side, fear of getting infected if they came to the hospital with their STEMI or their NSTEMI. And it was also from our side in fear of taking care of COVID patients for our own well-being.
Yeah.
So I think that fear factor is dramatically reduced across the board.
Yeah.
It's reduced. The patients don't have the same fear factor of getting COVID when they come to the hospital. We don't have the same fear factor of getting it from them. Most of us are all vaccinated. And you know, so I think that we're in a better world as far as this goes. And it certainly helps that the virus now is less virulent.
No, and just to confirm your point, Dr. Zera, I showed the slide earlier, is these are the cohort of patients, compare them from 2020 to 2021. Definitely they have better outcome coming with acute myocardial infarction and COVID between these 2 years. Why? Because we get to them sooner, because they are seeking the help faster. I don't think we did not invent in 1 year a new medication or a new surgical technique or nothing. It's all the same care. It's just a matter of awareness. And I think DMC has been very proactive, putting on the media outlet in terms, and I remember your advertisement on the radio, like if you have symptoms, don't wait, just come to the emergency room. And surprisingly, the drop in the patient coming with myocardial infarction was consistent with the drop in the patient coming with stroke, those coming with a GI bleeding. So everybody who has acute illness just give up. They don't want to come to the emergency room, scared from COVID. But now, as we showing here, and I think if we put a third bar for 2022, I think this number will be lower, and we're going to go back to the normal where we were before COVID. Don't you agree?
Yeah, no, I mean, I totally agree. And, you know, I'm hopeful that this whole pandemic is going to be that, you know, we get our yearly COVID booster, and it's similar to getting our yearly flu shot, you know, that's tailored to the current variant that's out there that year. And I suspect that's the direction that we're going in.
Right. In terms, last thing is about your comments on the blood clots. Like, as I mentioned earlier, these clots comes more. And I remember your team on ECMO, they usually, for COVID patient, you have variability in blood thinners. Either you need heparin or you don't need. Can you please tell us how did you manage these patients?
I mean, the classical wisdom of being on ECMO is that because you're running the blood through the synthetic surfaces, over synthetic surfaces, that you should be on blood thinner, whether or not it's VV or VA. Of course, VV is on the right system, the right circulatory system, and so you don't have to worry about stroke unless they have a patent foramen ovale. But it became very, very clear that our patients were bleeding. And so by far the majority of these patients, we would try to run on VV ECMO with no anticoagulation. And that became kind of a lifesaver for some of these patients, because we ended up, you know, some of these patients just bled and bled and bled, and they just bled from around their cannula sites, from their tracheostomy sites, in their GI tract. And then, like I mentioned, we had three mortalities from intracerebral bleeds. So there was no question that there was a bleeding diatheses on ECMO that this virus caused. So we just adapted the way we do things to be very careful with anticoagulation, follow them much more closely. And we have a multidisciplinary team taking care of these patients that round on them every day. Of course, the pharmacists are very involved in anticoagulation, and we just kept closer track of their clotting cascades than we would say just a normal ARDS VV ECMO patient.
Dr. Zera, again, one of the things that was kind of enlightening is to see how many people you decannulated after COVID. So just tell us, what is the shortest period of person was on ECMO, and what is the longest period?
For COVID was horrible. Normally, just to put it in perspective, normally an average VV ECMO run, according to the ELSO database, is about 14 to 16 days, somewhere in there. And our ECMO, our long-term COVID survivors on ECMO, our longest one was, I believe, 105 days.
Wow.
So 3 months. We had several patients in the 90-day range. We had some that were shorter in the 40-day range. but it wasn't like the standard. A lot of us cut our teeth on H1N1 back in 2009. That's when we first started doing ECMO for viral, for the viral related pneumonitis, pulmonary pneumonias caused by the viral pneumonias. And those patients, the average ECMO runs, like I say, were 16 days or so. The longest, my record up until this time with the COVID was 75 days. And here at the DMC, we ran many patients out longer than that period of time. And we learned that persistence pays off. These are very young patients. They're going to go on and live a lot more years. And so it's very, it's very fulfilling to see them discharged to home at the end of all this.
Absolutely. We have a question from Dr. Jeff Gangas. I was wondering if you have any data or opinion on whether COVID patients have increased risk of cardiac stent thrombosis compared to non-COVID patients. I don't have, definitely there is an increase. From our center, we didn't have that surge. I remember one case was stent thrombosis, but the patient did not take their antiplatelet, but happened to be COVID positive. So whether the COVID expedited the process, I'm not sure. When we look at the NACME registry, which is 300 plus patients with COVID, only was 2% of them presented with acute myocardial infarction due to stent thrombosis plus COVID. So definitely it has an impact, but I think there is direct impact and indirect. Direct impact is by increasing thrombogenicity as well as the thrombophilia. But number two, one of the patients also had no access. They didn't go to the doctor and refill their Plavix, and therefore they ended up having a stent thrombosis.
Yeah, I just want to make a comment. For those who don't know, Jeff Kangas, who asked that question, is one of our critical care specialists in the ICU, who's well-versed with taking care of these patients over many, many, many months and now years. I want to springboard off that question, just one other question about that. Has anybody looked at patients that have stents that were COVID positive that ended up presenting with stent thrombosis? I mean, in other words, has anybody looked at the entire cohort of patients that present with COVID positive with an acute coronary syndrome with stents?
I see. Nothing that I recall.
That have already been stented.
Yeah, that already been stented. Yes, a good question, but I don't know if I came across such publication. Personally, I did not look into it, but definitely I think somebody did or in the process of looking into this, because the N is small. The N of these patients is small. It's going to be a case series more than a big registry. There's one more question here. Does COVID-19 cause any valvular heart disease or impact on those who had artificial valves? I think that's more like mitral valve, mechanical valve, or biprosthetic valve. Have you seen such a thing, Dr. Rosaire?
No, I haven't. No, I was thinking, I just read something recently, but about COVID effect on valves and whether or not it had a potential similar effect as fen-phen. I just read an abstract, and but I don't want to comment on it further because I don't really know. I'll have to look that up. But no, I'm not aware of thrombosis of valves any more than the general population or anything like that.
Great. Yep. But that's a good question, actually, to see if there's something like that. But for a busy surgeon like yourself, Dr. Zera, I mean, mechanical valve.
Yeah, it's interesting too. I don't even know if anybody's really looked at, say, there's something like 6 million patients in the United States that are on Coumadin, chronically on Coumadin. And I don't know if anybody's looked at whether or not there were more bleeding diatheses in those patients if they became COVID positive or not. I'm sure that's out there in the literature. I just haven't seen it.
Right. And any other final comments or questions from the audience? I know we finished early, but the topic is really been engaged a lot on still till now in media, and we're still getting these media outlets reach out to us to comment about the vaccine, what kind of vaccine they get, and if this certain vaccines affect the heart disease or affect the heart in different way. one of the things I would like to highlight, and this is something I have a personal experience, but again, I have an N of maybe 13. One of the rehab center across the building from our heart hospital is a cardiac rehab. Usually they have firefighters as well as medical EMS employees who got COVID, they got sick really, and they go through a robust rehab program to get them back to the job. And usually, oftentimes, they have palpitation, heart rate is fast during, and extra proportional to the amount of effort they're putting. Usually, they are young and fit individual, or they drop their saturation. So they come to the cardiac clinic for evaluation and also for what's called clearance to go back to the job or to the strenuous physical therapy. And it's interesting to see out of 100% of the time, I do the same workup. I give them a Holter monitor. I do exercise stress test to see how was it functional capacity, as well as echocardiogram. Everybody passed these tests, meaning there's no ischemia in the heart. I never took somebody to the cath lab because their stress test was abnormal. The Holter monitor always shows sinus tachycardia, but no any malignant arrhythmia such as AFib or SVT. And these patients have a good functional capacity, but they drop their saturation, but for sure their heart rate is exponentiated, meaning if their target heart rate 140, said, doc, I'm just, as soon as they start going inclination, my heart rate shoot to 180. And to be honest with you, I have no explanation to that, except that what the first slide I mentioned earlier is the inflammation. It's an inflammatory process. It's going to take some time to recover. I never prescribe a beta blocker or any antiarrhythmic medication for these patients. And oftentimes within 6 months, everything goes away. How it happened, sometimes up to 6, also 1 year. And it's funny because the younger these patients are, the longer the recovery will get. And I think this speaks to the strong immune system that respond to this kind of infection when they get it. Seems like we're getting one more questions. Does COVID increase myocarditis? We touched on that earlier. It does cause, one of the features or manifestation of heart disease in COVID patient is myocarditis. As a matter of fact, is majority of the presentation when somebody comes with elevated troponin due to COVID and COVID, they have some sort of myocarditis. Now, the ultimate diagnostic tool for it is to do what's called cardiac MRI to see if there is any enhancement by injecting a dye called gadolinium in these patients, if there's any enhancement and uptake in these muscle cells, but we never routinely do this test. If the patient's troponin goes down, if the patient has no symptoms, if the heart squeeze function and ejection fraction is normal, then everything, I don't think there's necessary to do that extensive workup. However, if the patient continues to have a decline in their ejection fraction or symptoms continues, then you have to be more aggressive in pursuing that, especially in younger population.
Well, Chadi, thank you so much again for your insights into this complex disease process. And just want to thank everybody for attending this evening, and enjoy the rest of your evening. And remember again that this is a CME event, that you can get CME credit for it. And also that this will be edited and put out on our website for referral to people who are interested and to re-listen to it if anybody's so inclined.
Thank you, Dr. Rosera, for your time, and really your insight, and as well as your comments is phenomenal, given your experience and the time you spent too much time treating these complex patients during the pandemic. And hopefully we don't go back to these times, but if it happens, I think we know how to deal with it now. I hope you have enjoyed this DMC Medical Group video. To find more content, webinars, and physician videos, visit dmcmedicalgroup.com.